So before we had talked about the three different procedures that we do use for HS, and they're all used in different ways. You know, for some people, it's a very small area. For some people, it's a big complex operation. But the most important thing that everybody's asking right now is, if it's not curative in nature, why even bother doing it? Okay. Ooh, hello. And does HS surgery work? Well, part of the reason that surgery has had such a bad reputation in the past, I got to stand actually. It's like the mind. Part of the reason that surgery has had a bad reputation in the past is that we've treated it like cancer in the sense of we've always looked at recurrence rates. But now that we understand that it's a systemic disease, that it's something that we're trying to work on, how do you live with this disease and how do you manage this disease? All along, we've been looking at the wrong goals for surgery, okay? So each person is going to be looking for something different. Are you looking for less pain? Are you looking for fewer flares? Are you looking for less isolation, an ability to work, right? A lot of people miss a lot of days from work and they can't work, or school. It's another big one, intimate relationships. So I focus on quality of life. What can we do for you in terms of your quality of life that would make it helpful to you? And let's set reasonable expectations for that. So where is surgery done and who does HS surgery? And one of you mentioned before, I'm confused. There's general surgeons, there's trauma surgeons, there's plastic surgeons, there's dermatologic surgeons, and then there's also dermatologists. And the short answer is it's for physicians as well. It's not a one size fits all. So first of all, you have to have someone who understands the systemic nature of HS and what the goals of surgery are so that you can help. That's how you know that you have the right fit surgeon, in addition to feeling comfortable and so forth. If you have a small area or even a relatively small area that could benefit from a procedure, if it's something that can be done under local anesthesia with you awake, there are a number of different dermatologists, Dr. Daveluy included, who does those procedures in the office. As they get bigger and bigger and the magnitude grows and the extent of it grows, that's where you may need to enter the operating room. And that's where you'd be looking for someone who has credentials to function in an operating room. He's more comfortable in the office. I'm more comfortable in the operating room. The reality is I do things in the in the office too. But what I'm just trying to explain is there's just a difference in skill set. We're doing the same things. We're just approaching it very, very differently. And the tools, including the anesthesia that I might have available in the operating room, might be different than what Dr. Daveluy has available there. So let's talk about the different surgeons. Most surgeons complete the same basic training, okay? And as much as this topic is confusing and it seems very complex, from a surgical standpoint, it's actually not very complex, okay? As long as you have someone who understands what the principles of everything we're trying to do are. So whether or not you go to a general surgeon or a trauma surgeon or even a plastic surgeon, surgical oncologist, it doesn't matter per se, provided they understand the disease. With plastic surgery, there are some excellent plastic surgeons out there who work on HS. But the one thing to remember is that plastic surgery tends to focus on cosmesis. And everybody says, well, that's great, right? They're going to make it look good afterwards. We have to balance that. We have to balance all those closure types. We have to balance the extent of all the other things we're doing. And I'll show you some other options for closure, because sometimes it can end up, if we get too fancy, it might actually get to the point where that's not what you wanted, that from a cosmetic output standpoint. So when people come to me, the frustrating things for them is when they've seen other surgeons, not having had realistic expectations set forth in the first place and not understanding what was done, or they're really unhappy with the cosmetic disfigurement. Okay, so let's talk about cosmetic disfigurement. Mastectomies. Someone was talking about that yesterday. I can't tell you how often patients are offered a mastectomy for breast disease. So now in everything that you learned today, mastectomy means taking off the breast. And you take off the breast tissue and you're taking off all that, remember the deep fatty tissue? You're taking out not only the skin where the disease is, but you're taking out all that deep fatty tissue underneath that gives you your contour, and then you're closing the skin. So what's going to happen, guys and girls? Well, it's going to come. It's not fixing the problem. It's a systemic issue. I see a lot of people who develop disease in the entire suture line, which is basically all the way across the chest. Now, for some people, there are some folks out there who may say to you, well, I had a really good experience with this. And this was a decision that they obviously made, but you don't need to do this. Okay. There's never in my mind a time where you have to do a mastectomy for HS. Okay. Let's talk about the labias. So the labias are the lips, okay, going down on the female area and the vaginal area. So the vaginal HS in the past has been traditionally operated on by GYN oncologists, so surgical gynecologists. And similar to how the mentality was to treat this like a cancer, what do? You cut off the labias. So the labias, like the breasts, I know it's real. It is okay. So the labias, like the breasts, it has all that tissue there. Now the labias are a little bit different, okay, because the disease in the labias actually tends to tunnel deep into the fatty tissue, whereas the disease, for example, in the breast doesn't tend to do that. So there's still opportunities to try to avoid cutting off the labias. The only time I will ever remove like full labias, so to speak, is sometimes you can develop changes in the tissue called lymphedema or edema. And at that point, there's really not anything significant you can do once you've tried all of the different measures to do it. But otherwise, what I'm telling you is to tell your folks that only in the very rare situation should they ever agree to get their labias cut off, and only in the very rare situation should they ever agree to get their breasts cut off. Another point I want to bring up right here is colostomy bags. Has anybody heard of colostomy bags? Okay. So
Stephanie, can I add one thing to that?
Please.
And a good clue for them, because sometimes they're like, well, that's all the surgeon talked about. If that's all the surgeon talked about, that's the wrong surgeon, because they are not discussing the options like Dr. Goldberg just did and said, we can do this kind of surgery. If all they're saying is, all I do for this is mastectomy, that's the wrong surgeon. They don't have the toolkit. They don't have the skills to do all the things that need to be done. So that's a good clue for people. If the surgeon only brought up one option with you and didn't talk about, and it was mastectomy or taking off the labia, that's the wrong surgeon.
So colostomy bags. So a colostomy bag is where your intestines, which go to your butt and your butthole, instead of the poop coming out down there, we basically from the inside attach it to your belly. Or here, so that the poop can come out of here. And it keeps the poop away from your butt, okay? So why do people do this? Well, everyone with significant buttock, like perianal and or disease around the butthole used to get these. And unfortunately, they're still getting them. Those of us who are well educated in HS have really moved away from this. So you have to say, well, why were people doing this in the first place? So surgeons did this for a couple reasons. Number one is that they were worried if they did extensive surgery down here, it wouldn't heal well if the stool was coming out. Okay, so they wanted to move the stool to the other place. So it comes out here and it bypasses that wound while that wound heals. Well, the reality is that we leave these wounds open anyway to heal by that secondary intention process. We actually do that so they don't get infected. Okay, so these wounds, open wounds, don't get infected the same way that closed wounds can get infected. So the open wounds can get layers of gunk on top of it, which could impede the wound healing, but it's not going to get infected in the same way. So that's one reason that they did them. The other reason that they did it is because people thought it was very infectious in nature, and surgeons just didn't know what to do other than, well, let's give them a colostomy bag and then the stool won't go through there and they don't have to worry about the stool coming out. So even today, you have all these people who are floating around with colostomy bags that were put probably 10 to 15 years ago. And it's interesting because when you talk to them, they don't have a good understanding of why they even got the bag in the first place. And it's major abdominal surgery. And I'm guilty of this too, okay? When I finished my training, that was what we did. We would, especially with people with really, really bad disease all over, okay? We would admit them to the hospital for somewhere between 6 weeks and 3 months. So think about that. You leave your family, you leave your job. I have 2 ladies, if they're listening, they know who they are. They're my special ladies. And gosh, I think I operated on them in like 2015 or so. But they actually overlapped in the hospital. So as recent as 2014, 15, we were still doing these big, big surgeries. And I actually introduced them to each other so that they had company in the hospital and they started going over to each other's rooms and getting wheeled over. But we used to admit people to the hospital. Sometimes they would get colostomy bags. They would go back to the operating room every day or every other day for wound care, and then they would go home. So we don't do that anymore, and we also don't do the colostomy bags for everyone anymore. Your followers all know about these, okay? Because the first question I get when people come in is, do I need a bag? And the answer is no, I don't need a bag. Okay. Now, here's the next layer of that I'm going to make things even more complicated for you. You can have buttock disease. I'm really excited. I'm touching my butt on live stream TV. Okay, so you can have butt disease. You can also have disease all around the butthole. Okay, like in deep. You can also have disease that actually communicates with the inside of the butthole. Okay, those are called fistulas. And some people have fistulas with Crohn's disease or with they just have fistulas. Some people have it with HS. And fistulas are very hard to treat. And that was another reason that a lot of surgeons like to do the colostomy bags, because they thought, well, if we just pull the stool away, then the stool won't go through and won't keep those tunnels going directly from your colon, your intestines, out, not your butthole, but the sides by your buttock. Well, over the years, I've taken a much less aggressive approach to this, and I always do that last. Okay, so instead of doing those big surgeries where someone's admitted to the hospital, they stay in the hospital for months or days. We do series of smaller operations. We plan it where you go home the same day. And then, when we do the next operation? So first I want to make sure that you're healing well on the first operation. After that, once it's looking pretty good, when you're psychologically ready, okay? Because the first surgery is always the hardest for everybody. You don't know what to expect. It's frightening. Your family doesn't know what to expect. But after that, you kind of get in a groove and get excited. And if there's another thing I want your folks to know is that be excited about surgery. What it can do is really, really, really amazing. And I love it when people come into the office. So everybody cries in my office, which doesn't make me feel, we'll cry together. But by the time they leave, they're hopefully excited, but a little frightened. And then the day of surgery, they're typically really, really excited. And that makes me incredibly happy. So going back to that and going back to those fistulas, the connections that come out of your butthole, a lot of doctors are really, really worried about these because there aren't good treatments. But let me tell you, Now that I've been less aggressive with those and save those to the end, I've never had a patient come back and say, this is bothering me. Okay. So even if they have them, even though you have something going on, it doesn't mean that we have to do anything surgically to it. So let me pause there because we just talked about labias, breasts, buttholes. You can get it in your belly button too, by the way. All right, let me give you a quick word about armpits. Okay. So every region of the body is different when we talk about surgery. And the outcomes of the different regions of the body are a little different just because the disease presents itself differently in the different areas. So the armpits are like gold, okay, or diamonds or moissanite, whatever you call it these days. They're amazing. And the reason they're amazing is because if we do an excision and take out the whole area, the chances of it coming back are very, very small. I hate to use the word cure, but we can get you as close to a cure as possible in the armpits. Okay. Now, the armpits can be a little challenging, and they can be challenging because if you have a lot of scar tissue in there or a lot of, and it's been going on for a long time, it can go deep into the armpit. And there's some important structures in the armpit. There's the major blood vessel, so the nerve, the artery, and the vein that go to your arm, and that's the only one. They supply everything there, so you don't want to mess it up. Okay. That being said, so that's a space where I'm a big fan of doing those in the operating room because it's a more controlled setting. Whereas if you're in an office, if you're doing small little excisions rather than the big ones, you can definitely do it in the office, but sometimes you can start cutting and people realize that it actually goes deeper than it is. And it's like, oh, oh goodness, we got to stop. This isn't going to work. And I see that time and time again. So just remember that surgically, if someone is afraid of surgery, armpits, the way to go and the way to start. Okay. And then, oh, please. Mm-hmm. For your arm. So, and this is one of the great examples of how keeping that mobility is really, really important. So if you close it primarily, you close it at the time of surgery, your arm is stuck at your side. If you leave it open to heal by secondary intention, your mobility actually improves. But you're right, you can't just sit there with your arm at the side all day. I actually have people start doing exercises. You need to go to a physical therapist. A lot of times it's not going to be the scar tissue building up. It's going to be more of your shoulder joint, or sometimes the muscles get so tense in there that that's what's restricting your motion.
And if you have a new active spot that you think could benefit from surgery in that armpit, when they do that surgery, they might also be able to release the tissue where then when you recover from this one, you'll be able to get that mobility back. And then there's a couple other things that hasn't been really like well studied, but there's case reports where like someone thought it was a good idea, did it for a patient, it worked. So they report it of using some of our lasers to help with scarring. Because some of our lasers shoot these tiny, tiny little laser holes to kind of like let things release a little bit. So there's some other options for that too, or like you said, like physical therapy. So there's options. It doesn't like reverse the damage, but it's a way to treat what needs to be treated to help with it. Yeah, to improve things.
Yeah. And that's the thing. If you operate on scar tissue, what happens? You get more scar tissue. Okay. That's the way the body heals. So you have to make sure that it's not going to happen again, and you have to do everything possible to minimize that from happening again. Please.
So, when I had all the nodules and stuff in my underarm, I felt like there. I don't know if it was like a tendon, but it was like I could see,
Yeah.
something like that. And I even still feel pulling on it. So physical therapy will like stretch that back how it's supposed to be.
Well, your surgery, if I recall, was fairly recent. That will soften up over time as well. But otherwise, massage, physical therapy can be really, really helpful. And self massage can be really helpful to just rub the area and then just practice stretching.
I had a follower that said that they're in Dubai and that they don't have any of the options that we've spoke about, they only have antibiotics and painkillers.
Mhm.
Do you guys know if like they're going to be having surgeons that are going out there and stuff?
So we do have some, don't we? We have a couple who are involved who I think come from that area.
So yeah, and we can reach out
Um,
because we have this kind of like list of HS people, and we can reach out to it. And I know Cleveland Clinic is opening a dermatology office in Dubai. Now I don't know who's going there, lucky person, but I'll see if I can kind of find out. So there may be things coming. And then like we said, if they have anyone that they can kind of reach out to, or even reach out to like the HS Foundation, we can kind of reach out and see where people are and what they can get done. And because yeah, I mean, even within the US, a lot of people don't have access to an HS expert, to someone who does HS surgery. We do have a clinic finder on the HS Foundation website, so you can go on there, put in your state. We're constantly trying to get more people on it so that people have more access. But yeah, unfortunately, a lot of people don't really have access, and we're trying to change that. If they have someone who is willing to try, if they put in my last name, Daveluy, in YouTube plus deroofing, I have a little instructional video that's like 3 minutes long, and it teaches people, like doctors, how to do the deroofing because it's so easy. If they can cut a cyst out of somebody, they can do deroofing. I always just tell them, just start small. Don't start with like a massive case with 1 million tunnels. Start with one little tunnel. So we're trying to get people doing it and trying it because like Dr. Goldberg said, I always tell the docs, you do your first HS surgery, do something small. Let the patient know it's going to be a little bit of a bumpy recovery. You might regret it for the first couple weeks, but then when you get out to like the 6th or 7th week, 8th weeks, and it heals, the patient's back going, okay, next, which one are we doing next? And the doctor's like, wow, that's so awesome. I want to do more of it. So you get like hooked because it's so effective for when you have those tunnels that just keep draining when everything else is doing good, or those spots that keep coming. Earlier, someone was saying like, I have this one spot that always comes and goes and comes and goes. That needs a little surgery, and then it won't do that anymore. It'll be gone.
Just to add on to that really quick too. So HS Connect in 2025 is looking at a global approach, and we're already working with the UK on trying to, have a more global presence and including information in different languages based on countries. So we are working on doing that. So it's going to be a long process to get everybody on board, but we are already in the process of starting this. So just keep that in mind. We also have we call it a dermatology list that starts out with the HS Foundations list, but we also take patient referrals. So if somebody has a great experience with their provider, then we'll add them to our list, or providers will reach out to us and say, hey, can you put me on your list? I treat HS. So it also has some for, we have some in the UK, some in Canada, and then, a ton for the 50 states. So it's a good place to start too.
Is there anything in India going on?
Somebody just asked about India the other day, didn't
the
they?
guy with the backpack
Yeah.
at the meetings.
Yes. Oh, yes. Yes.
He can,
Yeah.
there's one Bangladesh we have.
Yeah.
There is.
There is.
And the other piece of this is there's a large national study going on called GISA, which is it's the global health impact of HS. And they're looking at HS in all the different countries to understand what does it look like in different populations of people and how does it affect them. So what we can do is find out who the India representative is, because I suspect there's more than one.
Yeah. Yeah.
You guys can always email me, like if you're looking for follow up afterwards, like feel free to email me and then I can circle back around and get the info.
Yeah.
One more question. So if someone were to get HS only in their underarm and then have surgery, do they have the chances of it going to another area on their body?
You never know, okay? Because the reality is that since it is systemic, you're absolutely right. You could get it anywhere, but you may not. So I have plenty of folks who just have it isolated into the armpits. We do surgery, and so far so good. But we still don't want to think of it as curative, We still want to recognize that it's systemic.
And that also comes up when people will get them under good control with the medication. We'll do some surgery, and they're like, I don't have any HS on my body. I haven't for 6 months. Do I need to keep my medications going? And we're like, I'm nervous to stop them. So sometimes we'll slowly kind of take things away or space them out a little bit, but we're always cautious because we're like, it's there. We are probably just controlling it right now. But then at the same time, sometimes there are times where it's like, oh no, it's done. I'm just backing off my meds and doing good.
I have a question. You know how like once again, I don't know why I keep associating it. It's the best analogy I can get. You know how you get tested for STDs and stuff like that. Is there a way that we can find a solution to get tested for HS so that when it goes away and when it comes, we'll be able to understand if it's gone?
I
That's
wish.
tough. Yeah, it's tricky. HS right now it's a clinical diagnosis. It
In my head right now, that's like rushing me is we're saying a word for it, but what is it actually, and how can we identify it when we actually do the experiments and stuff like that? How can you identify HS? How can you know if it's there and if it's not? I think that's the route that should be actually.
We spend so much time talking about that. Like there's this whole group called Historic that's the outcome measures, and that's they've tried so many things. They've tried like heat vision cameras to see is there inflammation in there.
It's over after that.
Right. Yeah. Yeah. We have worked so hard, and we're getting better, but they have some of the tools where like if you're in one of the clinical trials, they say, okay, is your disease active? Let's count the number of spots you have and rate this and rate that. And they'll have two experts do it on the same patient at the exact same time, and their scores are different.
It's like a cycle. What if you guys actually found the cure so many times we would never know, and all you did was just bring it back by doing more things to the person? You understand what I'm saying? Like, what if it's gone, but then you gave something to bring it back, and you just would never know until you know when it's actually gone?
Some of that, I think, one of the things that helps us with that a little bit is like if you don't treat it, it's very rare that you hear somebody's like, oh, I didn't do anything and it just went away. Like, so that from that, we know it's a chronic disease. It doesn't just go away. It's not like a cold where like, I'm going to have a cold for 2 weeks and it's going to go away. Or it's not even like COVID, where COVID, most people got it, felt kind of crappy for a while, got better. Then some people had a little bit longer problem, couldn't taste anything for a month. And then some people have long COVID and still have stuff. HS is much more the opposite. Like, yes, there are some people where at some point it seems like it kind of goes away, but that is definitely the rarer case.
The scariest thing, right? Because like with cancer, you can figure out when it's gone. You can figure out when it's like, okay, you have no more cancer. So you can identify the issue. But
Well,
yeah.
cancer's
it's yes and no.
remission. Yeah.
Yeah.
So they follow you forever.
Your hand has been up for a while, so let's go to the back corner.
Yeah.
Oh, in an office setting. Yeah.
Just reminded me, how willing are you guys to bring in other doctors to work with for individual patients, because we deal with different comorbidities a lot of the time, and not just other autoimmune or autoinflammatory issues. It's the psychological effects that it just has on the patients. And I have other doctors who are unwilling to bring in other doctors because, oh, I know what I'm doing. I know what I'm doing.
Nope.
Right? Yeah. What can you say to them other than I'm a different doctor?
So with that saying, that's a whole other talk, which we are happy to give you, is how do you optimize what's what we call it, a patient for surgery? How do we get them ready? What are the things that we can change or alter? What doctors can we use to partner with in this team of healthcare providers to set you up so that you'll have the best possible outcome, whether it's controlling your diabetes, whether it's trying to decrease the smoking. You'll hear that a lot from the plastic surgeons. They may not be willing to touch you if you're smoking. Now, that's not my philosophy, because the reality is that these wounds heal and they heal pretty well. Now, if we were doing a skin graft, it might be another story, because that's an area where the smoking could really, really negatively impact things. But the reality is that, and just taking smoking for example, it does drive inflammation, which is why it can have an impact on your HS. It is a nightshade, so it's inflammatory in nature. I don't care about your lungs and the impact it have on lungs, okay? And that's what I tell people. However, in it can decrease oxygen that goes to the skin, so it can impair your wound healing. Is it significant? For most, no, it's not that significant. It would only be in some of those fancy plastic surgery type procedures that we're talking about.
Towards, for me, I have plastic surgeon, I have a dermatologist, I have allergists and
Mm-hmm.
pulmonologists, and for me, luckily, they all talk to each other.
Yep.
For medications.
Yep.
But there are so many patients that have medicines that they're on for their HS or for something else that knock against each other.
But the issue is that the doctors don't understand. So they don't appreciate and value the importance of understanding what that impact of that medication that's being treated by the rheumatologist. They don't even understand that it's a systemic disease. So they can't put all the dots together. I think coordinating with all of the physicians and your team of physicians is incredibly, incredibly important. And what you'll find in the HS world is we all kind of have our people who we collaborate with in the region or nearby. And we tend to partner with them because we trust them.
Yep. And the bigger problem a lot of us run into is getting people willing to see HS from those other specialties, and people that are doing a good job with it. So like I've sent to a surgeon before, patient came back, told me what they talked about, never sent to that surgeon again. Well, reached out, talked to that surgeon, agreed with the patient that I'm never sending anyone there again. And so we do a lot of that too, where you build your team, like what are the other doctors I need to work with? And then I also have to like educate them. So I love my plastic surgeon. She still tells every patient they need to stop their biologic, no matter how much I tell her they don't. So I tell the patient, like, yeah, you're going to stop it. You're going to stop at the last dose before surgery and start at the next dose after. Just, if you stopped it,
Yeah.
then just tell her you stopped it.
It's
Hopefully she's
interesting.
not watching.
I have this really sweet girl that I actually just operated on in all her armpits and her bilateral groins in the course of 2 surgeries. And she needed a special drug, which we're not talking about today, that was goes in a big IV, and she gets it at home. And I don't write that drug. It's appropriate for an infectious disease doctor or not a medical doctor to write, not a surgeon. I couldn't find anyone who was willing to do it. So I found a guy in the area, and I said, "Have you ever done this?" He said, "No." And then he said, "Let me pull the data so I understand, and let's talk about it." And and we did it, and she had a great outcome, and everything was great. So it does take a while.
So is laser hair removal even really beneficial for HS?
You want to answer that? I'm a big fan, but this is his area of expertise. So
So it can be beneficial. And we have studies that show it. There's also, there's different types of lasers, right? But it looks like anything that targets the hairs can help with HS. It's not consistent for everybody. It's better for early stage 1 and 2, because once you get a lot of scar tissue, it's harder for the laser to get in there and get the hairs. And a lot of times, once you have a lot of that scar tissue, there's not really visible hairs left. There's probably little remnants of hairs that are still growing and causing problems under the surface. So it's not as effective for that. It's also most effective in areas that have thick hair. So armpit tends to work the best, followed by the groin. That least effective under the breasts, because there's not a lot of hairs, because the laser targets the big dark hairs. Doesn't work very good for white hairs, for gray hairs, blonde hairs it even has a little trouble with. Sometimes in terms of picking the right laser, it might depend on your skin tone. So some work better in darker skin types at getting the hairs and not damaging the skin. Other ones work good for light skin types, dark skin types. It takes a series of them. So usually it's like 4 to 8 weeks apart. So every month, month and a half. And you need 6, 7, 8 treatments of it. But it can be an effective treatment. Some of the studies show, granted, this is for like people with earlier disease, that it can be effective in like 60 to 70% of people. I love it for early disease. Like when mom brings daughter in and she's like, she's starting to get HS. I'm like, let's do laser hair removal. Let's get rid of that hair. And there's one study out of Germany that proved that it could be used for like prevention. Because a lot of our studies, we include people who have moderate to severe disease, because it's really hard to show something works for mild disease. Like if you get an abscess twice a month and I put you on a medication and you go down to once a month, it's like, well, that's better, but did the medication do it or did it just happen? So it's usually later disease. So it's nice to have some evidence for that. If people are looking to get it covered by insurance, the HS Foundation has a section on the website where your doctor can get a letter to send the insurance that tells them it's effective. Here are the studies. Here's what we want to do. On the HS Foundation website, so hs-foundation.org. They're called like prior auth letter templates. And tell doctors about them because we got everything on there. Every medication is on there, Botox injections, the laser hair removal, the surgery, because we know that is a big hurdle for people is getting things approved, getting things covered.
There and like take it to them.
Yeah.
You know,
And they fill out that information and send it to the insurance company.
Yep.
Yeah, it's
Yep.
basically like
Yeah.
Yep. And it's got all the heavy lifting. They basically add like your name and your insurance number and then send it in if they want to elaborate a little on other things you've tried. But yeah, so it can be effective. And they'll talk to you about, there's some risk of like discoloration when you get it done. Usually it's temporary. It's hilarious because when we do it just for hair removal, we talk about that. People are like, "Ooh, I don't know if I want discoloration." When I talk to an HS patient, they're like, "Do you see what I see? Like, are you kidding me right now? Do you see what the HS is doing? That's fine. If it's discolored, but it doesn't hurt and drain every day, I'll be happy."
So I want to just, that was a lot of information and he did a great job, but I'm going to just summarize it because this is an area that's so confusing for people. So laser hair removal or laser therapy can be used, we think, to help prevent disease by killing the hair follicles before it gets affected. The other is that it can be used to treat early disease by targeting the hair follicle that are already starting to have problems. In severe disease with the tunnels and things like that, that would not be an effective approach to take. And what I tell folks, especially the early ones, is try it. And if the worst thing that happens is that you don't have hair growing and you don't have to shave if you want to, then that's the worst thing that happens. I'm sorry. Yes.
Are there ways to test the level of inflammation in your body?
We've looked at that. So, and that's actually, the short answer, we've looked at that in various different ways. From a systemic standpoint, you can, and there are blood tests, but they're not specific to HS. They're specific to inflammation. We have so many inflammatory diseases that exist. Anytime your body's stressed, anytime you have an infection, those levels are going to be high. So it is hard to track. That being said, I do have some patients where, I have seen surgery will also help decrease your inflammatory levels. You may have all heard, this is actually kind of neat. Have you heard of the anemias, the blood loss or the blood levels being low? It's actually a chronic anemia. It's not from you bleeding from your wounds. That's a myth, okay? It has to do with things that are going on deep in your body, so your blood levels are low. If you have a lot of disease, and when I'm talking about lots of disease, I mean active inflammation, that red area, like red inflamed skin all around, a lot of times when we get that under control or do surgery, your blood levels come right back up. And then you feel better because you're not going to feel good if you don't have a lot of, if your blood levels are low.
One of the other, go ahead. I was going to say, one of the other things I talk to my patients a lot about is knowing if you need medical therapy, surgical therapy, or both. So a lot of times we start with medical therapies to calm things down because surgery is going to go better. And then I tell them the spots that come and go, new spots, medicine's really trying to calm those down, calm down that inflammation, the redness, the swelling. And then we once we get that under control and you're saying like, I'm not really getting a lot of new spots. I don't have a lot of redness and swelling. We look at what's left, what is still there for like this tunnel's still draining or this one spot just kind of keeps coming and going. And that's how we kind of figure out what you need in what area. So that's just like one of the strategies, but it's a pretty good approach to it is to sort of figure out, because sometimes it's hard. People are like, they come in to see me and they go, I need the surgery. And I'm like, well, you do, but we got to optimize the medications and get things as calm as possible first.
Yeah.
So get it under control as much as we can and then go after. Sometimes I tell people HS is like a house fire. So the flames are the inflammation. We use medications are like firefighters who come in, put the fire out. Then we assess the damage that's been caused, and then we bring in the carpenters, and the carpenters are our surgery, and they got to fix the damage.
I'm a carpenter. I don't think I can put a nail in a wall. So, but here's the thing. If everyone were treated we know that medicine and surgery work best together. Not everybody has access to that care. Okay. So if we waited for everyone with HS to first see dermatologists, they wouldn't, there's not enough dermatologists in the world to take care of it. So you have to look at where do people seek medical treatment? And there's a number of people who come first to surgeons. And we have to make that decision of, do we want to treat this medically before we operate, or do we think we can do some things simultaneously while we get you a dermatologist? Or is your disease so focal in one area, so isolated to one area, where I say, you know what? Let's just try surgery. Maybe you don't even, like you were talking about before with like the people who just have an armpit, you take out the armpit and they never have a problem before. That's not unreasonable either. So what I want people to know is that you don't have to be on medication before we do surgery, but our thoughts are that they're kind of like best friends, okay? So why? Okay, well, the idea is we talked about tunnels and nodules and all that kind of stuff, but the surrounding tissue can get very inflamed as well. If we can decrease the inflammation in the surrounding tissue, we can do less of a big operation. So your cosmetic outcome will be better and it hopefully will heal better. So that's the whole premise by trying to combine the two. We also think, although we haven't shown it yet, that if you're on a biologic medication and you have like a heavy burden of disease somewhere and we go and we cut out that disease, hopefully the medicine will work better. Okay. Oh, actually, that's right. We do.
We have one study
Yep.
that showed that too, where they combined the two and they showed the medication works better when the surgery goes in and takes care of those ones that it's like, oh, medicine's not going to touch this tunnel. Let's cut the tunnel out. And then like Dr. Goldberg said, because there's inflammation kind of coming from the tunnel and irritating things, all of a sudden other areas get better. We actually see that sometimes. So our laser hair removal studies, we would do it on half the body. Like we'll treat one armpit, and then the other one is the untreated side to compare and show. And it was a little bit of a struggle because sometimes the untreated side would get a little better too, because we're just kind of tamping down the whole disease state.
Yeah.
Yeah, and then we, of course, afterward, we're like, okay, now we're going to treat the other side for free as part of the study too. So we didn't let people like leave half HS and half not.
Yeah.
Did you still have a question?
Okay. So, couple things. Everyone's a surgical candidate. There is no one who's not a surgical candidate. Again, very different than how we used to do things. Okay. So you're a surgical candidate if you have a goal in mind and we can help you try to reach that goal. It's as simple as that. Okay. Brief word on how much does it cost? I hear time and time again that people have gone to other surgeons or other physicians and they're charging them a lot of money. Insurance won't cover it. Insurance covers this.
It still costs a lot. Damn.
It depends. It's going to depend on your insurance. It depends if you have a high deductible. If it depends on what your copay is. It depends on if you're in network. But the reality is that all of these physician procedural codes for hidradenitis are covered by insurance. So just keep that in mind. The piece that's typically expensive is the wound care supplies. Okay. And Brindley talked about how she orders wound care supplies on Amazon. Most insurance companies cover wound care supplies, especially after surgery. So you see me in the office and we actually fax over a form, because fax still exists in this world. And it has all of the information on what the anticipated sizes of your surgery, of your wound is going to be. And they send you a box of supplies, most of the time at no additional cost. And it's most of the time, again, excuse me, it depends on your insurance. But that way you have everything at your home and you can get them. Same thing with people with chronic wounds. If you go to a wound care center, for example, you can often get all of your supplies through insurance. If it is cost prohibitive, that's when people start buying them by themselves. And on that note, go ahead.
And you're probably wondering, like, okay, so if insurance covers wound care supplies, why are all doctors not writing for them? You know, we hate fighting with the insurance about the medications. The wound care is a totally separate section of your insurance that doesn't go with your pharmacy. It doesn't go with your medical benefits that pay for office visits. It's this durable medical equipment, a totally separate section with totally different rules. And it's just a huge pain. So if people don't do it and get used to it, they dabble, they try, they're like, all right, I'll try for some wound care supplies. And then the insurance goes, we don't cover that one. What else do you want to try? And you're like, well, what do you cover? They're like, we're not going to tell you, but if you keep submitting things, eventually you'll get one right. But we don't give a list out. I was like, well, give me a list of what you cover. And they're like, no, we won't. So people get frustrated. Like that's some of the medications that need a lot of prior authorizations, like the biologics. There are some derms out there who just don't do them. Because like at our office, we have someone we pay and it's her job to talk to insurances all day and get things approved. So some people look at that and go, I can't afford that in my practice. I can't have someone just talking to insurance all day. That like, where does that person's salary come from? And we're like, it's just a service that you do for your patients. So that's why and we're trying to get people better about it. And I'm hoping someday AI is just going to do it. Like it's, instead of it being Martha, I love my Martha, she's great, but I just want it to be like AI Martha, who insurance says denied and AI just sends like 100 letters a second until they prove it.
Yeah.
So we'll get there. If you guys are good at AI, like, or anybody watching who does AI, start doing prior authorizations with AI.
That really quick. One of the things that's really helpful, especially if you're switching doctors or insurance, is to keep track of what medications you've tried and when and for how long, because that really, really helps the physicians get through that prior authorization practice much faster.
So,
Especially if you change insurance, because the new insurance doesn't know all the stuff you tried before.
okay, I'm going to take your question 1 second, but I want to tag on to one thing he said. If you're ordering wound care supplies from insurance, you might hear that they don't cover it. It's not that they're not covering it. They're not covering more than a certain number per month. So there are all kinds of different wound care supplies and dressings, especially advanced wound care supplies and dressings. And some insurances will say, well, we only cover 10 per month. Okay. So just also bear that in mind, that ask questions. Ask, will they cover a different type of wound care dressing? How many will they cover? And guide your physician in this, because they just may not know. And I'm sorry. Go ahead. So it's never been a better time in the history of the US to not have insurance. Okay. With Medicaid expansion and all the different programs that exist, pretty much everyone can get access to some kind of care and some kind of insurance. You just have to know how to ask. But there's financial, if it's someone who's, for example, has insurance but out of state, for example, or their insurance won't cover it, a lot of times we can appeal to them to get it covered. If they don't have insurance, we can sign them up for Medicaid or one of the federally funded types of insurance. Hospitals also have what they call financial screening. So you bring them your financial information and they're going to work with you. They want you to get care. So it's a good question. It's another myth.
And I often tell people too, because sometimes people are sort of like, insurance is expensive. Let me just see if I can like make enough to pay for this. And I'm like, in the long run, you're going to save money by getting insurance, even if it seems kind of a high price tag, because things add up quick. Like the surgery, it's expensive. The medications are like prohibitive. Like you cannot pay out of pocket for a biologic. They're like $30,000 to $40,000 a year.
Yeah.
Granted,
Surgery's way cheaper.
The insurance does not pay that amount. They negotiate a better deal, but that is if you pay cash to try to get it. So it's just, there's like this whole system that's so stupid with that, and rebates and everything. It's a whole nother advocacy piece we're working on, is like the corruption of that whole system.
Yeah.
Ugh.
And if you don't qualify, so there in different areas, there's a number of immigrant populations who've come over who don't necessarily have access to care. There are federally qualified health centers that can provide care. There's a lot of options. And if what I'll tell your followers is, if you ever run into a problem, ask for the social worker or the care coordinator at a hospital. They spend a lot of time trying to help people get hooked up into the system so that they can get that ongoing care. Ooh, my favorite.
You want to see my armpits? They're so pretty.
Ah,
The cosmetic outcome, like how it looks after.
all right. So
Yeah.
So it's gonna depend, okay? Is the short answer, because it's gonna depend how you heal. Everybody's genetics of healing are very different. It's gonna depend on the extent of the area. It's gonna depend on, do we go ahead and take out all of that tissue that gives you the contour, or do we stay on the level? So here's a picture of an armpit. Here is your before. And that disease has actually calmed down very nicely. In this, I decided to do an excision, and you can see comparatively where I cut and went around, and this is it healed. So
She didn't stitch it up.
I did
just
not stitch it
letting
up,
it
yeah.
heal because the scar contracts. So as it's healing, it shrinks. So it's kind of amazing. Like you've got this huge open skin, and then the scar, you're like, oh, that's actually not that bad. It's pretty small.
minimal. But I will tell you, I have I actually, we've published on this before, and keloids are very difficult to treat. We can use radiation therapy. We can use intralesional steroids. We can try excisions. HS and keloids have a very interesting relationship, because the question becomes, is the HS driving the keloid? And if we get rid of the HS, will we get rid of the keloids? And I have had some patients where we've had luck at finding the tunnels that are literally in the middle of the keloids, getting rid of the tunnels, not the keloids, but getting rid of the tunnels. And then a lot of times the keloids kind of flatten out a little bit, so you don't have to do anything further. I do have one patient who developed recurrent keloids. It's tough. It's very tough.
But yeah, it's reassuring that it's more rare than we would expect. Because like Dr. Goldberg said, sometimes you look at someone and it's like your HS is causing kind of like keloidy scars. So you're nervous, but then you cut it out and it heals fine. And it was really the HS that was making things not heal right, which HS just loves to do.
All right, so here's a breast picture. And this method, I call this cherry picking. I hope Brandley's told me over the years that's not offensive in any way. But when I talked about people who have their HS all looks different, sometimes it's one area, sometimes it's spread out. So how do we help all those people? We're not going to, whose disease is all kind of spread out everywhere. I say, show me what's bothering you. Okay. And then we go and we pick out those spots. So the neat part I want you to see here is, so this is this. Okay. This is this. All this skin is red, but there's no tunnel or anything like that for me to deal with surgically and look at the outcome when it heals. So you have scar. This is fresher scar, so it's a bit pinker. And that does fade over time, but you can see that the tissue around the inflammation just shrinks down, which is pretty cool. So that's what I recommend for this kind of stuff. 6-ish weeks, give or take. I tell for the armpits, I tell people about 3 months, but it doesn't mean that you're not functional for 3 months. Okay. So keep that in mind. It means that you will have a wound, and the first 3 weeks are really the hardest part in terms of the wound being a little deeper. You're getting into the rhythm of doing the wound care, which is a little different than your other wound care. But the wounds heal from the bottom up and then the outside in. Once you get to the bottom up and it's filled to the top, it's like autopilot. No, you can go to, you can go to the gym when you feel up to it. You have no restrictions with the surgeries that I do. In fact, no, I have a college kid right now who, she's had 2 surgeries and she's going wild at the gym. You are not going to hurt anything. Okay. Yeah. You don't have to sit home. If you feel good the next day, you go. If you need, did you have a skin graft or a primary closure? That's why, because they closed it.
Yeah, when they close it,
Yeah.
they're afraid you're going to rip the stitches. That's why we're trying to push people, like, just don't close it. It heals great. You don't have restrictions. It's so easy.
You can get in the shower the next day.
Yeah.
Oh, wait, I'm sorry. I think, if you don't mind, I think she had her hand up first. Neither.
Yeah, we
Leave it open.
We want it left open.
We want it like this.
That's our favorite.
But look at this for a second, okay? Look at the edges of this. If you close this, This could fall apart. Look, the skin around it, this is all inflamed skin. This is not normal skin, even though there's no HS disease there, and the disease that was in the wound was causing this inflammation. You're asking for it to fall apart.
And we opened up all those little pockets. We don't want to close and make another little pocket.
Yeah.
But like Dr. Goldberg said earlier, the traditional thing was sew it up. So we're trying to teach people, because this is really hard for surgeons to be like, I'm just going to not sew it up. They're like, no, I sew everything up.
Correct. Yeah,
Yes,
especially
yes.
Yes, especially the plastic surgeons. You're absolutely right. Oh, I have a picture. Okay. I'll show you the neck first. Okay. So here's a neck, and the neck is another great area where same patient. That's a little blurry, but you can see how you only see the area here. That's the problem. When you open it up, check that out. Okay. So this is an excision, and then this is how it's healed.
And sometimes you guys know that, right? Like you come in, I'm like, oh, it's just draining right here. You're like, yeah, but if I push here, it's going to come out of there. And I'm like,
Yeah.
okay, it's all connected. And
Yeah,
we feel for it. We try to tell.
Well, it's funny because people will say, "Oh, I need to show you pictures of what it looked like however long ago," and I'm happy. I say to them, "I'm happy to see the pictures, but I know. Don't worry."
So, you said 10 weeks ago?
Yes.
So I had mine stitched up as well, but I was only down for about a month, and I was fully healed after that.
hmm
What's the difference? It's like,
Everybody has you.
yeah, so I was doing too much.
You weren't doing too much. That doing too much doesn't cause an infection. Okay,
That I didn't have any pain at all, even after the narcotics were off. And then I went out, partied, and it was the middle of summer, so I was sweating. So I was thinking all of that had everything to do with getting infected.
do you shower?
Yeah.
It didn't. That's not what caused your infection.
And honestly,
What caused your infection was all the things about the tissue I'm sorry.
But my surgeon did say that it wasn't infection.
yes.
It was draining clear liquid.
Yeah.
Yes.
Yep.
Like, it's draining too much, and I was freaking out.
That's what I was
Why
gonna
we
say.
stopped closing them.
Yeah, and there's
Because
a lot of complications after surgery that are not infection. But if you go to ER or urgent care, they are 100% going to tell you it's an infection no matter what, because they're just like, I don't know, here, antibiotics, go home.
Yeah.
So there's a lot of other things that can happen. It opens up, it's draining more, it's inflamed. And if you, certain doctors will be like, oh, it's infected. And I can't fault them for being cautious, but they don't say like, I don't think it's infected, but let's do a little course of antibiotics to see. They just go, it's infected.
Yeah.
So we see that a lot
the-
where people come in, they're like, it got infected. And we're like, no, it didn't.
And they get mad at us.
I had the surgery, and then like maybe 2 weeks later, I was like, no, something was wrong. So he brought me back in because I kept pestering him, and then did whatever he did, and then after that, like I was great.
Yeah.
Yeah. That's why we've moved away from closing these. Some people do have good outcomes with the closures, but again, it all depends on what's going on in the surrounding skin. The things that you need to heal are good blood flow in any wound, good blood flow, lack of infection, and lack of inflammation, and then no tension. You need all those things to heal a wound. HS is setting you up for failure. Plenty, because from a number standpoint in the U.S., 3/4 of people with HS are skin of color. Now, and actually, I have a great example of one where I'll show you something. So, obviously, there's a lot of skin differences in terms of the melanin and so forth with skin of color, and Dr. Daveluy can speak a lot more articulately than I can. But what I find is that the majority of my folks, after a big area that's cut, most of the time it's actually fairly pigmented, okay? But I do have some people who do develop literally a pigmented scar, okay? So I do caution people ahead of time that could be an option or an issue that occurs. It typically is only on the butt. I don't see it on the armpits as much. Well, that to me looks what I would expect, in yours. But yours was closed, so yours is different. It's different. Scar's going to be different when it's closed than if it's filling from the inside out. Yes, ma'am. On their back? Absolutely. And that would be more of a cherry picking,
Yeah.
a targeted approach. What's bothering you? Where are those? Your spinal cord is so deep. This is a skin disease, and it sits on the outermost in the next layer of the skin. It should not go down into that fatty tissue, with the exception of some situations where we do see it. We don't know why, but for the most part, it sits on that layer.
I have one very deep. Would you recommend or suggest, so people who have like stage 1 flares that they're not very deep, like there's this silicone scar tape that you can get, like put it on there. Would that help with their scar?
So,
I'd be nervous.
Yeah.
Those telescope scar tape don't really let your skin breathe very good. So we use them for keloids, which is great because they kind of choke out the keloid a little bit. But with HS, I'd be very nervous. I've never seen anybody use them, and I'd be nervous that it would actually trigger flare-ups because you're blocking things up, kind of blocking all the hair follicles and trapping things inside and causing more inflammation. If they wanted to do it for just like a keloid, you can trim them to just that size and just put it on top of the keloid, so that way it's not blocking up all your hair follicles in an area. But yeah, I'd be real cautious with those because of that. We call it occlusion, where it kind of blocks everything up, like putting saran wrap over top of your skin, like it can't breathe.
but let's go back to the stage 1 and the scar. Okay. So when you think of stage 1, it's a little bit of inflammation. Okay. So using that silicone that's more targeted at a scar type situation anyway. What we really need to do is talk about how do we decrease that inflammation with either medication or intralesional steroids are amazing. A little steroid injection in the doctor's office can go, it's a lot easier and faster than doing any kind of surgery.
All of the steroids, right? So like, would that work for people who have other, just like, something like I have PCOS and diabetes? Like, if could I then go in and go that route of, let me just get a steroid, and that not affect anything?
Yeah, because Dr. Goldberg, the key term there, she said intralesional. So that's our fancy medical term for in the spot.
Thank you.
Yeah,
Yeah,
so injected like right, and we say intralesional, which means in the spot. We actually kind of put it right
around.
next to it, around it. Yeah.
Yeah. Yeah. I just had it in my ear because I got a cartilage pierce because I thought it'd be cool to do with my teenage daughters, and I got a hypertrophic scar.
Yeah.
So I can tell you it does hurt.
But a lot of times it'll give relief if you're flared up within like 24 to 48 hours. And then there's some,
Yeah.
yes.
Yeah.
Inflamed. Yes.
And then that hurts, yes.
Real quick, do you have
No, it's not. It's not as bad.
So the
Yeah.
purpose of strip gauze. So strip gauze was something that was really used more for abscesses, okay? Not necessarily HS where you have that lining, but more of you got a pocket of infection unrelated to HS, and they open up the skin and they make a really small incision, and we want it to heal from the bottom up, because what sometimes can happen is that the skin can heal before everything else down below, and it just traps bacteria in there and you get more. Okay. I hate those packing strips. It is awful. They're difficult to pack it's cruel and unusual punishment. If you ever have anything you need to pack, take a small piece of gauze, twist one corner, moisten it if that's what you're doing, and jam it in there. Yeah, no. If I never see that again, it's going to be too soon. Yeah, but no.
And the worst part about packing is like HS is not an infection. They usually use the packing for the infection, kind of keep it open. Because like Dr. Goldberg was saying, we don't want to trap things in. Open wounds don't really get infected. But there's actually not good studies to show that it even helps with infection. Yeah. So it's probably useless all the time and just torture for no reason.
Yeah,
it was somebody like had a good idea or thought it was a good idea to put this antibiotic soaked gauze in there and pack it. But yeah,
No Someone told you it's not.
Yeah, and a lot of
Oh,
people
yeah.
now, if you go to the ER and you get drained, for an incision and drainage, some people they're not even packing them anymore. It's because the purpose isn't to get it to heal from the bottom up anymore. We know that we're leaving that disease behind. Oh, we'll let you guys arm wrestle for who goes next. Oh, is there a sack? Yeah. All right. Hey D, will you bring me up that bag of food? All right. So we'll get there in a second. While we're doing that, I want to talk about a couple of the more severe cases because when I said that HS affects different people different ways, I don't want people sitting at home saying there's nothing they can do. There's nothing they can do. This is a dear patient of mine who came in, and you can see all this stuff going on. You can see the disease going towards his butthole and so forth. And what we did was a series of smaller surgeries, starting with this area. And this is how it closed. This is as it's healing. And then we went to the next area. By the time all was said and done, this is where we were, and this is what it looks like. I just needed to cauterize that little area, and he has done fantastic. So this was a couple of surgeries done over the period of about a year, I would say, give or take. And you can see that we still had to do this part. That's right. But you can see slowly but surely, you develop the scar, the wound contracts, and you can get a really good cosmetic outcome. The other piece of that, so here's another butt, okay? That is left butt. And this is a patient who, when he healed, he did have the very pink scar left over. And that does soften up over time. It's really hard for about the first year, and then it just kind of softens up as the scar matures and remodels is what we call it. So I do. Well, yes and no. We play a game, okay? Well, it's not a game. But the first thing I ask you when you come into the office is, do you work? What do you do for work? Do you work in person or are you behind the desk? Who's at home with you as adult-wise? And are you responsible by yourself for small children or things like that? Because all of that is going to help me figure out what the plan is for you, what the timeline of how we're going to do things are, what we can put you through. If you don't have any help at home, then we can't put you in a situation where your whole life, including your financial stability and possibly your home, is going to completely fall apart. So the short answer is I typically start with the areas that are worse. I let people choose. If there are a couple different, I will combine anatomic areas. The butt, I don't like to do the butt all at once. And the reason is that think about if the stool is coming out and you got to wipe to poop and you got raw skin or raw tissue on both sides, that's going to be incredibly, incredibly painful and uncomfortable. Same thing with the groins. I tend, if it's an extensive groin excision or deroofing, I tend to only do one side at a time. But sometimes what I'll do is I might do like the left butt or the left, like, think of like you're yeah, exactly. That's exactly. Exactly. And then we come back and do more. So what I want to point out is this is not an excision. This is a deroofing, and this is a complex deroofing. So see all of this? These are all little tunnels that are going through with scar mixed in. And sometimes there's disease located in the scar. And we don't cut it out because there's a lining in the tunnels that is good tissue. And if you keep the lining, that's what will help preserve the contour for you. So we spend all this time kind of teasing it out. This probably takes a couple hours. This is the wound care that we use with the special felt that I talked about. This was when we went back the second time. Oh, I didn't put the other picture. It's this part. Do you see that? It's this part. So we did this part first. I always start from the outer side and work my way in because a lot of times it will cross over the middle. And he's still healing a little bit right here. You can see that area. And then we were moving on to the right side. But that kind of gives you a sense. So he's still got his contour. Women and men are different with how they present with HS. Men's tends to be more severe on the buttocks. Women do not tend to, not everybody, but do not tend to develop disease like that. That being said, I do have one woman.
And while she's finding that, I have a lot of patients who come in and when we're talking about surgery, they're like, just do it all at once. I just want to have like one recovery period. Yeah.
Mhm.
Yeah. It's a challenge. And that's what a lot of times I'll say, like, can we do like a small one first, just so you can go through the process and then you'll be able to tell me if you want to do it all at once. So I'm like, let's yeah. Yeah.
There is hope for everyone, even the worst of cases where the skin is completely ulcerated out. This is my sweet lady. You know who you are. She just texted me Happy Mother's Day. She came in with this whole area ulcerated. And remember we were talking about like the granulation tissue versus the jelly? So, yep, this is jelly. Yeah, she literally had a hole. No, her butthole is down here. That's where all this stuff is coming out, actually. But they gave her a colostomy, and we never figured out why they gave her a colostomy, other than someone just gave her a colostomy. So, in any event, we actually use some fancy medicine that can help with surgery to decrease inflammation. It's unfortunately once you stop it, all the inflammation comes back, and it has to go in an IV in your neck, and it's great for certain people. It's not necessary for most people, but we use that. And the neat thing is look at how all the inflammation around the skin has now just melted away. This is the inside lining of a giant tunnel. Okay. But it's more of like a cavity. So what do? We removed all that stuff. And then here we actually rearranged some tissue, and look at her butt now. Yeah. So she had a,
The question with the sac, what Dr. Goldberg's getting at is there is a lining that we got to get out, and then it cures or it heals and it gets better. It's that jelly gooey lining. When they look at it, it's got little stem cells from some of your ducts that are normally like your ducts in your skin, and we think that's what's that?
it's a sweet ropes.
Yes.
It's,
Made me not want to eat them anymore.
I may have eaten some last night.
So cysts, like not HS cysts, but cysts, if someone just has like a random cyst, those have this little lining of skin. You get it out, it heals. So that's where sometimes doctors are kind of thinking like, well, I heard there's something I got to get out for HS. I'm going to call it a sac, just like I do for a cyst. But it's not exactly a sac with HS because the cyst sacs are like much easier. Like you get in there and it's this little thing and you pull it out. It's like a balloon. Those are way easier than HS. HS, you get in there and you got to like scrape the lining out or yeah.
One that I got when I was 15, 16 years old. Stayed open for turned into a kind of graduate one. Didn't know what it was. Didn't have my diagnosis at that point. So they kept testing for staph, all this like that, all this stuff they did.
Yeah.
And then after about 2 years it closed, didn't open up. And then about 2 months ago, it filled back up to the size of a balloon and then went back out. It opened up, didn't do anything. And I'm like, but I have this like right where it's at. But what's the recurrence rate of that one? Because
That is a tricky one. During that 2 years where would keep draining, that's when there's that active lining and it's just not going to heal and it's going to keep draining. Then when it healed up, I don't really know why. And I don't know if the lining kind of went into like dormancy. And it might be that actual spot kind of got better, but then a new spot popped up right next to it on top of it, kind of. It might be one for surgery, but it's a hard call because if it's not really so active now, if sometimes though, I have patients where they have one like that where like it's not always active, but it comes and goes, and I can always feel something under there. And I'm like, let's just see what's in that something under there. So we might look for a tunnel and try to open it up. And if I can't find a tunnel, I'm like, we're just gonna take this out. We're just gonna get that thing out of there and get rid of it and let it heal in because yeah. Right. I thought we were friends again.
We're at 4:40, so
Okay. So this is a tunnel. Okay. It's just one tunnel. And like I said, but I want to show you how easy deroofing is. Okay. This is actually how I teach residents
Do you need me to hold it?
how to do this. Well, I don't know. I don't know if she's going to cut you. So here, the lining of the, or excuse me, the tunnel itself, the wall of the tunnel is the red. Okay. Whereas in the real thing, the jelly would be at the red. And inside, this is filled with white stuff. So what we need to do is we need to open up the tunnel, take off the top or open it up so that we can see looking down into it and scrape out all the yuck in there. Make sure all of your viewers can see this.
Do you want me to hold it? Okay.
It's okay.
Oh yeah, that works.
Oh yeah, you'll be good.
I don't have all the equipment here, but at least we can start. You like it? I have more scissors if people want to play. Don't try this at home, please. Okay. Honestly, the real reason, they bleed a lot. In the more severe disease, I can't do them in the office even if they're small because the jelly is so densely adherent to the lining that you can't stop it without cauterizing it. So, okay, so open it up. You might get some stuff on your nails, on your beautiful nails.
What is the tissue called? Hard
That's the epithelial lining or the Okay, now do this. Cut out another piece of red, like turn it around like this, and cut off another piece of red.
Almost like the way they cut.
Uh-huh.
They used to
There
cut
you
on
go.
the subway, where they
Oh, that's true. Okay.
It's like, what are you talking about? They used to
Okay,
take
you
it
can.
right
That's good,
subway.
actually. Okay, now cut this off.
But now, as I was
All right, so here's the top of the skin. Okay, we've now taken it off. I'm not going to eat it. Okay, now I want you to scrape out the crap. Well, not crap, lining.
yeah.
All right, very good. Very good. There's different ways to do this, but she's removing it. See the whites coming out? This is the best part. Actually, I think it's the combination of textures that make this candy so ridiculously good. And get this little part here.
I'd be a bad surgeon leaving all the stuff.
You're doing a good job. No, honestly,
Another tool if you were in the.
yeah, you would have a different
Yeah,
tool.
I'll scrape
I just
it.
don't have it here. But you actually don't even need to get all of it. That's the funny thing. There's some people in Europe that
Yeah.
we love you Europeans, but there are some studies in Europe where they didn't remove the jelly. I don't know how that happened. So look, this is the inside of a tunnel. This is the inside of all of this right here. And it just heals. Okay, that easy. If anyone would like to play, and I teach this on Reese's. It's product placement, brand marketing.
Right.
And I have more sweet tarts. So if anyone wants to play or eat, you come up and play or eat.
All the candy.
That's right. All right. Any other questions you all might have for us?
And so, I mean, I've been just
I can
bad information, but it's okay. So you were talking about knots, because when I was younger, my first diagnosis, I would go to ER, right? They showed me how to pack a wound. So I would pack my own wound down.
Mhm.
Did a video about a year and a half ago showing people how to pack their wound down. Apparently, we don't do that.
You do you.
So, so is that, I guess, bad for to pack the wounds, and does it not necessarily help out? Like, I've never had anything like split it out where it's like, oh, yeah, it's painful, it's scarring. Like, I mean, I've packed it and take it out. It's just.
So hold that thought. And this is with everything you do in HS. There's one question I want you to ask. What is the purpose? And if you can come up with a good reason and a good purpose that's going to help you, then the answer is absolutely go ahead and do it. Okay? So if for you, packing it provided some kind of advantage, I'm honestly not sure what it would be.
Right.
Yeah. Yeah, and right. No, you don't need to do that because going back to that theme of why we pack things, it's to keep them open to heal from the inside out. Kind of like what we're doing in here. Where's my felt? So this is packing. Okay, it's just the flat packing.
Yeah.
This is this is silver cell or silver alginate. I prefer Aquacell, but again, product placement. But there is a
Are
difference.
you hooked up to that too?
Yeah, go for it.
I'll just show you guys. if you have to go to the ER and get them drained next time,
He's famous just like you all are.
I don't have the
Please.
skills.
I have a question. I also wanted to respond to Crystal was asking. I did a lot of packing as well, and they told me not to do it myself. It's less painful to itself than someone else doing it. But the only reason why it wasn't essentially good is while you were swelling. Because I healed very fast when I was younger.
Mm-hmm.
So my outer layer always closed up when
Mhm.
on the inside was.
Yes.
I really want to hear because it was gradually push it out
Oh.
and make sure to
Making
find the outer skin.
So that's true for things that are true infection cavities, okay? But when you have the HS cavity, unless you're removing the gelatinous lining, it's not going to make a difference because you're leaving all that stuff there. So even if the skin closes, all that stuff is still there. It's not going to scar up in the same way. We can show you some pictures to help. I gotcha. Hold
Okay.
on. I'm gonna take care of you.
They-
Hold on.
I was kind of mad at
He
you
really
about
wants
this.
to show.
I put it, this video is an armpit, and I'm doing a little deroofing on it, and they flagged it as 18 and up.
Yes.
And there's a way to appeal, so I appealed. I was like, no, people younger than 18 have this disease and may need to see this video, but they do not budge.
It's not.
Oh, I got it.
Oh, why isn't it?
I
Oh,
got
you have
it.
to drag it.
So this video, next time if you ever have to go to the ER and they want to do incision and drainage, if you say, if you could just watch this video, please, and do this instead. So I kind of showed it for him, like, this is incision and drainage. There's this pocket of pus you're after. This is the skin surface. They just cut it. So deroofing is just cut off the rest of that skin that's on the roof of it. Instead of just cutting down the middle, just take that last little bit off. You don't even need different tools for it. Then I show them all the tools they need.
But you gotta scrape out the lining for it to
Yeah.
be a true deroofing, and that just may not be possible if you have an acute flare, because acute flares are very difficult to numb up. It has to do with the pH of the cavity and the tissue related to the lidocaine. It's very hard to numb up. So that
Yeah, it was.
yeah. And that's not always in everywhere, okay? Just keep that in mind. That's only in some of them.
So I show them, like, okay, you made your thing.
Yep.
Now here's the roof. You can tell what the roof is. Let's just take the roof off of there.
And we have on HS Connect we're getting the clinician page back up, but we have 3 versions of this, and Dr. Daveluy is one.
And they're awake for this.
Yep, awake. We just numb it up. They don't feel a thing. Yeah. And see, here's where I'm telling them, this is that jelly goo lining that you got to get out of there. See, like, oh, look at that jelly goo.
So the jelly, some people it's really like just stuck on there and it's really hard to get off, and other people you can literally just wipe it right off.
Yeah, sometimes just gauze. You just go whoop and it's
Yep.
gone.
But you see how it bleeds? Do you see how when you touch it, it bleeds? That's why if you have one and you get irritated, it'll bleed. Oh, I knew I was going to tell you. For the packing, when you have something drained in the ER and they leave it open, it's no different than if you had a draining tunnel. Okay. So basically they converted a non-draining cavity or non-draining tunnel to now a draining tunnel. And sometimes they actually never heal. That is one of the risks of doing an incision and drainage. So for some people, it can make quality of life worse.
Wonder if like, I know it's only, I doesn't really flare, but I mean, I'll drain forever.
Yeah.
Still drain, but like, I just like, okay, they started, I dropped it.
You have a
Weekend.
chronic cavity in there. That's just, and it's open and it's not going to close right now. And it's just just going to drain. As it makes fluid, it's just going to drain out. We can also disimpact you if you'd like. So hope we answered as many questions as we could, and come find us. We're happy to answer anything else.